My name is Pat Bray. I'm the Director of Community Relations for War Memorial Hospital, and I'm very pleased tonight to introduce Dr. Paula Rechner, who has been gracious enough to come tonight and talk to us about the genetic testing that the hospital does for breast cancer. So, Dr. Rechner.
Thank you for asking me to speak tonight on this subject. It's a very interesting topic, and I mentioned it to Pat a number of months ago when Angelina Jolie came out with her genetic testing and her decision to go through with bilateral mastectomies and reconstruction at that time. So I wanted to make sure that the people in at Sault Ste. Marie knew that we did have this genetic testing available, but it's actually fairly limited in those patients in which we're recommending the testing for. So more education is definitely needed in this area. So I'm going to talk today about BRCA gene testing, and I'm Dr. Rechner, as Pat said. I've been here for about 13 years, and I do a lot of breast cancer surgery, basically because I'm a girl and I have an interest in doing breast care. Breast cancer is our most prevalent type of cancer in women. It's also the second leading cancer causing death in women. In 2013, we're going to have over 200,000 new cases of breast cancer. Unfortunately, only about 40,000 of those women will die of it, but we still have women dying of breast cancer. So we're trying to find ways to improve our detection, early detection, and to improve finding out which patients are going to have that so they don't need to go on to die of breast cancer. So why do we get breast cancer? To talk about genetics, we need to understand how we get it in the first place. And we consider breast cancer, or any cancers actually, occurring because of our cells making a mistake. So every day our cells are dividing hundreds of times a day, and when our cells open up and split into two, there are proteins on the ends of them that have to be replaced with a mirror image protein. So when our cells come apart, we put a protein on the other side in order to make a complete cell. Normally, when we make these cell replications, the cells make mistakes all the time, but we have a tumor suppressor protein that comes behind, and we call it a spell checker, that comes back and it checks the cells to make sure that they have the right proteins in them. So those tumor suppressor proteins fail to fix that mistake, and if that happens, then that cell can go on to replicate and then produce a tumor. So there are usually 3 steps that need to occur in order for a tumor to start growing. So why do our spell checkers fail us? And the reason that they fail are genetic mutations. Genetic mutations come in 2 different types. They're germline mutations, which are inherited, and they come from our parents. And those cause about 5 to 10% of our breast cancers, and the BRCA genes are included in those, so we'll talk about those tonight. Also, there are acquired mutations, so those are not inherited. We are born with a normal set of spell checkers, we have a normal set of genes, but what happens is during our lifetime, something in our environment causes our spell checkers or our tumor suppressor proteins to not work properly. And radiation is a good example. Sun's radiation causes skin cancer. Chemicals such as tobacco cause lung cancer. Viruses like HPV cause cervical cancer, and then some of the reasons are completely unknown, and we don't know why our spell checkers or our mutations occur, and we end up with cancers developing. The acquired mutations are the most common cause of breast cancers. So breast cancers and genetics. About 10% of our breast cancers, like I said, are due to the specific mutations in single genes. They're BRCA1 and BRCA2, and those are located on chromosomes 17 and 13. And that's important because they are not sex-linked. They're not on the X or the Y chromosomes, so that means you could get this abnormal gene from your mom or from your dad. So your dad's family history is important too. And as we'll see in the sporadic cancers, it's more likely to have it be on your mother's side that those abnormalities will come through. So I'll explain that a little bit more later. There are a couple of other genetic abnormalities. On the P53 gene is Li-Fraumeni, and that's also related to breast cancer, though it's pretty rare. So is Cowden syndrome, which is on P10. And then the hereditary diffuse gastric cancer, which is associated with a specific type of breast cancer called lobular breast cancer. And that's one that sometimes isn't easily seen on mammograms, so that's one that's a little bit harder to detect. And that's related to the cadherin or the E-cadherin gene mutation. And I actually have patients in my practice who have BRCA1, BRCA2, and the E-cadherin gene mutations, but are not really that rare. We have them in Sault Ste. Marie. We have families here who have at least 3 of these 5 mutations. There's 6 on the next page. This is another list of the mutations. But we'll take a look specifically at the BRCA1 and BRCA2 there at the top. And the reason that those are important is because those women who end up with breast cancers and ovarian cancers have them younger than women who have regular breast cancers. Other cancers that are associated are fallopian tube cancers, male breast cancers, prostate cancers, and pancreas cancers. And BRCA2 is also related to melanomas and possible biliary tract and gastric cancers as well. So what are the BRCA1 and BRCA2 genes? As I said, they're genes that produce tumor suppressor proteins or spell checkers. They help repair or damage DNA so that it can't replicate and cause a tumor cell, and to prevent our cells from developing additional genetic alterations that lead into cancer. These are inherited, and they're linked to ovarian and breast cancers. They can be, like I said, inherited from either parent because they're not on the X or Y chromosome. They're autosomal dominant in inheritance, and that means that if you get one bad copy of the gene, you're likely to have the abnormality occur in you. So that means if your mom or dad has it, or sister or brother, you have a 50% chance of also having that abnormality. It's highly penetrant, which means that if you have an abnormal gene, you're very likely to have the outcome of that abnormal gene. Doesn't usually skip people, but it can. So how common are these genes? Well, the BRCA1 is 1 in 300 patients. That's not very, that's pretty common. BRCA2 is 1 in 800. And 90% of the early onset cancers in families that have both breast and ovarian cancers, you'll go back and look and they will have a BRCA1 or a BRCA2 gene mutation. So those are patients that we really want to pay attention to, ones that have breast and ovarian cancers, or if they have a breast cancer and have breast and ovarian cancer running in their family. BRCA1 and BRCA2 account for 20 to 25% of all the hereditary breast cancers, but only 5% to 10% of all the breast cancers. The mutations are found in about 15% of the ovarian cancers. And breast cancers tend to develop at younger ages than sporadic breast cancers, and that's the median age of 39. So if you think of a woman at a really young age of 39 getting a breast cancer, that's someone that we'd want to get tested. Cancers tend to be triple negative, and triple negative means that they have on their outsides of their cells, they are estrogen receptor negative, progesterone receptor negative, and HER2 receptor negative. And HER2 relates to a drug called Herceptin that is used to treat breast cancer. So those tend to be more aggressive, angrier breast cancers. They tend to be more difficult breast cancers to deal with. So if a woman has a triple negative breast cancer and they were diagnosed at age less than 40, she has a 36% chance of having a BRCA1 gene mutation. So we want to focus on those patients. BRCA2, in addition to increasing the risk for breast cancer, it also has a 2 to 6-fold increased risk of prostate cancer. So this is important for men because those prostate cancers tend to be more aggressive than the regular prostate cancers. Their survival is poor. Men who generally get prostate cancers have a median survival of almost 9 years, of almost 16 years, but those who have the BRCA gene survive only about 8 or 9 years. The BRCA1 gene does not seem to be associated with the prostate cancer, though. BRCA1 and 2 are both responsible for about 10 to 15% of the epithelial ovarian cancer. So although ovarian cancer is more rare, it has a higher incidence with the BRCA1 and BRCA2 genes. It's also associated with primary peritoneal cancer, and men can get that as well. So that is like ovarian cancer that grows on the surface lining of the abdomen on the inside layer. And I do have a patient in my practice with this as well. So it's certainly possible that we have a BRCA1 or 2 mutation in that family as well. It's associated with fallopian tube cancers. Male breast cancer, BRCA2 gene has a 7 to 8% risk of developing a breast cancer, whereas if you didn't have that gene, men would only have a 1 in 1,000 chance of having breast cancer, so significantly increased. So who should we test? Well, certainly women who have already a breast cancer, and then we look back at their history, so we're looking at the women who have been diagnosed who are young, less than age 45. If they have 2 breast cancers, and that might mean that they get a breast cancer now, and then they get a breast cancer in 5 or 10 years. But it's really important if they get a breast cancer at age less than 50, or if they have 2 breast cancers at the same time. I've had patients who've had breast cancer on both sides, and actually recently I found patients who have 2 breast cancers at the same time, which is really a difficult situation to deal with. If a patient has breast cancer and they have close family members who've had breast cancer at age less than 50, so young people in your family who have breast cancer, that's an important thing to look at. Or if they have somebody who has one of those triple negative or those aggressive breast cancers diagnosed at age less than 60. There are a lot of reasons why we test patients. They're kind of cumbersome, but I'm going to try and give you the overview. Also, women who have breast cancer, who have close relatives with breast cancer, diagnosed at age less than 50. If they have 2 close relatives that have breast cancer at any age, but then another with ovarian cancer. If they have close relatives with an aggressive Gleason score of 7 or 8 prostate cancer, we want to test them. Or if they have a male relative with breast cancer. Ethnicity also plays a role in this. The Ashkenazi Jewish population has a higher risk of BRCA1 and BRCA2 gene mutation, and also people from Iceland. Other patients who we should consider testing are those who have epithelial ovarian cancer, because that, although it's less common, it has a higher likelihood of carrying the BRCA gene. Men who have breast cancer should be considered testing for this gene. And also, if they have lots of pancreatic cancer, prostate cancer that's aggressive, or relatives with both breast and ovarian cancer. And then we look at patients who have no breast cancer themselves. So if you only have family history of breast cancer, we caution patients with the testing here because some of it is limited. It's always best if we can get the person who had the breast cancer tested, because then if they don't have it, then we don't have to worry that all of their relatives would have the gene. And then again, we're looking at clinical judgment. We're looking at all of your family members, taking a look at what ages they had them, whether they had bilateral cancer, if they were the triple negatives, if you had the bad prostate cancer in your family as well. So there is a huge algorithm that's very busy, and that's part of what we do when we do the testing, is we gather all the information from all the family members and then decide whether or not it would be a good test for the patient. So how much does that BRCA gene mutation really increase my risk? So if I was diagnosed with a BRCA gene, what does that mean for me? Well, it means a lot. I mean, you can see that the breast cancer is about 50 to 90% chance by the age of 70 that you're going to get a breast cancer. So not many women who have this gene don't get breast cancer eventually, which now it probably makes sense why Angelina decided to have her breast removed and do the reconstruction. Whereas in the general population, it's only about 7 to 8%. Ovarian cancer, 30 to 44%, whereas in the general population, less than 1% of women get ovarian cancer. Male breast cancer is 1 to 0.5% versus 6 or even 7 to 8%. And some of these numbers are a little bit different because it depends on what study you're looking at, but they're all pretty close in the same range. Second, primary breast cancer, more than 50% of the women who have a BRCA gene mutation are going to get another cancer. So when I'm talking to them about having breast conserving therapy, it's important to know if they have a BRCA gene mutation, because maybe it's not a good idea for me to recommend that they save the breast. It might be better that we take the whole breast off or decide to even do bilateral mastectomies for those women. So it's important for us to know if a patient has a BRCA gene mutation, sometimes even before we decide to do their surgery. The women who have a first breast cancer are at an increased risk for a second breast cancer, but that number is only about 2 to 11%. Looking at it a different way though, only 1% of our population is going to have a BRCA1 or BRCA2 gene. So as you see, the percent of population is only 1%. 90% of us are going to fall into the category without any positive family history or without a BRCA gene mutation. So most of the cancers are going to fall into that category. But what happens if you do have a positive family history of breast cancer? And about 10% of us fall into that. So I wanted to show you a list of this because this is important. Even if you don't have a gene mutation, your risk is increased because you have family members who have it. So if you have any family history of breast cancer, your relative risk is about 1.9. And then it depends on if it's how close they are related. First degree, your moms, your sisters, your daughters, about a 2.1, versus if it was an aunt or a grandmother, it'd be about 1.5. If you only have one relative, it's about 2.1. 2 first degree relatives, it bumps up to 3.6. And how old are those family members who, when they got the breast cancer? If they were less than 50, their risk increases by 2.3. And if they were over 50, it's 1.8. But look at what happens if you have a family member who had bilateral breast cancer. Your risk of having breast cancer is actually 10 times the relative risk. So that's an important thing. Even if you don't have a gene mutation, even if you don't fall into the BRCA1 or BRCA2, you still have an increased risk for getting breast cancer. First degree relative with ovarian cancer, if it's your mom, it's 1.3, and if it's one of your siblings, it's 1.26. So how do we do the test? Well, the first thing we have to do is to collect all of that information. We need moms, dads, sisters, brothers, aunts, uncles, grandmas, grandpas, great-grandmas, great-grandpas, cousins, all of that information, because we consider first, second, and third degree relatives important in this. So that's a lot of information. We need to know what cancer they had, how old they were when they got it, and whether they had one side or bilateral breast cancer. And then prostate cancer, how bad was their prostate cancer? Was it a normal prostate cancer, or was it a really bad prostate cancer? And then the next step is to counsel the patient regarding the risks and benefits and limitations. It's a very good test, but it's not a perfect test. You can get a false positive test, meaning that you actually don't have the gene, and you could get a false negative test, meaning that you have the gene and it didn't show up positive. The sensitivity and specificity are very high, and that means how good is the test? 95% or higher. So it's a really good test. I would trust it if I needed to have it done, but it still isn't perfect. So we have to make sure and let patients know that. What do? We simply collect the DNA, and there's two ways to do that. The easiest way is to have the patient come in, we collect your spit. We have you put scope in your mouth, swish it into a cup, spit it into a little container, do it again, send it in. You can't eat or drink anything before you come in, not gum, Tic Tacs, nothing. So that we get all the little cells from inside your cheek, and we send those in and they can test them. If you don't want to collect spit, we can do a blood test too. Most patients don't want to actually have a blood test, so we collect a lot of spit. They're both effective and accurate. So why would we want to test for these genes? Well, if you have a lot of family members who have breast cancer, it's kind of unnerving. You really don't know where you are, so there's a lot of uncertainty, so it's kind of scary. And if the test is negative, which most of us would have a negative test, that's very reassuring. That doesn't mean you can't get breast cancer, but you wouldn't get breast cancer due to that gene. For patients who don't have cancer yet, if they did have a positive test, there are risk-reducing therapies that we can do, and we can increase the surveillance and start it earlier. For patients who already have a breast cancer, I talked a little bit about that. It'd be important for me to know, because I'm going to recommend maybe a different treatment for them. Maybe breast-conserving therapy isn't a good choice for them. And also to get information about the risks of their family members. And a lot of women who have this test done want to know, because they want to know what to tell their daughters and their granddaughters. So what happens if I have a positive BRCA gene test? Well, we can increase the surveillance, we can put you on medications, and we can do preventative surgery. So increased surveillance, we start breast exams at 18 to 21 annually, and then semi-annual clinical breast exams, meaning a nurse practitioner or physician, beginning at the ages of 25 to 35. So that's significantly younger than what we regularly recommend. The yearly mammography and MRI beginning between the ages of 25 to 35. And normally we don't even start mammography until you're 40. We do have MRI at War Memorial Hospital. I'll talk a little bit more about that later, and I use this test as needed for patients. Annual or semi-annual transvaginal ultrasound and testing for CA125 to screen for ovarian cancer is another important component, and we begin that very young, at age 25 to 35. Medications that we can give, we know that tamoxifen has been shown to reduce the risk of breast cancer in high-risk women, so that's certainly an option. And oral contraceptives may increase or decrease the risk of ovarian cancer in women with either the BRCA1 or the BRCA2 gene mutations. Surgical intervention is also important. Preventative mastectomy significantly reduces the risk of breast cancer in women with the BRCA1 or BRCA2 genes, but it's still not zero. All of the breast tissue can't always be seen. There's a thin layer of fatty tissue that occurs in women, and so sometimes you can end up with a little bit of breast tissue that's left behind and develop a cancer in that. And then also the other part is whether or not you want to save the nipples, because the nipples can create a breast cancer later as well. So in order to do a true prophylactic mastectomy, the nipples need to come off too, and that's a sensitive area for some women. preventative removal of the ovaries, called a bilateral selfing oophorectomy, and I use that abbreviation so you recognize it on the next page. And that significantly reduces risk of ovarian cancer, but also of breast cancer in women by getting rid of the estrogen hormone. So on this slide, you can see tamoxifen will decrease your risk by about 50%. Mastectomy, almost 90%. Taking out the ovaries will reduce the risk of breast cancer by about 65%, and ovarian cancer more than 90%. Oral contraceptives then will decrease the risk by about 65% for ovarian cancer, but doesn't affect the breast cancer. So then we thought, well, why don't we take more than one therapy? If one's good, why don't we try two? And you can see that if you have bilateral mastectomy and both of your ovaries removed before 40, you have a greater than 90% decreased risk of getting breast cancer and a 90% decreased risk of ovarian cancer, so that's very effective. Removing the ovaries and starting tamoxifen, 85% decrease of breast cancer and 95% decreased risk of ovarian cancer. Removing the ovaries before 40 and breast cancer screening, well, it still has the effect of removing the ovaries, so it's about 40 to 50%, but it still decreases the risk of ovarian cancer at 95%. But the alarming thing on the bottom is that breast cancer screening and ovarian cancer screening really doesn't reduce your risk at all. All it does is tells us once you've developed the cancer. So if you're considering having the test, it's important to know whether or not you do anything with that information, because having the information and not wanting to do anything might be a really hard thing for you to do. So what are the common questions about testing? One of the biggest ones is, can I be denied insurance? And there are a couple of laws that keep the information or help protect you. One is the HIPAA Privacy Act, meaning that if you had the test done, I can't tell anybody about it, but if you have your records released, then I have to release those records as long as you sign for it. The GINA is a Federal Genetic Information Non-Discrimination Act, and that covers health insurance, meaning that you can't be denied health insurance and you can't be denied being employed based on your genetic information. But it doesn't cover life insurance, doesn't cover long-term care insurance, disability, or employers with less than 15 employees. It doesn't cover the U.S. military or TRICARE, the Indian Health Service, the Veterans Health Administration, or the Federal Employees Health Benefits Program. So I always tell patients, if you're going to have this test done, make sure that you have all of your insurance in place ahead of time, because once you have it done, I can't lie, and you're not supposed to either. So make sure that you get everything organized ahead of time. The Affordable Care Act will prohibit variation in premiums, meaning they can't charge you more for your health insurance based on your status and genetic information. So there are provisions in that as well. More common questions: how much does this test cost? Well, it's about $3,000, which is a lot of money. But the important thing is that insurance does pay for the testing. And if we follow the criteria that I listed, which I know is really busy and certainly needs to be done on a more personal basis for patients, if we follow that criteria and send the information in, generally, if you fall into one of the categories, the insurance would pay for it. You'd still be responsible for your copay and deductible, but that's it. So what Myriad does, is the company that we use, is they'll take the sample, they'll submit it to the insurance, and if the patient is going to have to pay more than $250, they'll call us back and say, hey, ask your patient, do they want to pay for the test? This is how much they're going to be responsible for. So that it helps take some of the guesswork out of it, because it's very complex. And where can we have that done? I do it in my office here at War Memorial. Generally, we schedule an appointment to go through the genetic information to make sure you're a good candidate. And then if we can do it that day, we would do it that day. Otherwise, my nurse, Amy, would go and collect the spit. She does the spit collector. She's very good at that. I'm happy to say that War Memorial has this test. We also have MRI, which is a very important thing. MRI is a very important test for women with the BRCA gene, but is also important for women who have breast cancer. Recently, it's helped me diagnose an additional breast cancer in women who it changes the way that we do the surgery, and also can tell us information about their lymph node status. So we certainly use MRI in patients who have had a really confusing course as well and have very dense breasts and difficult exams. So sometimes we can get it paid for. Our tests are sent out to Flint. They're read by MRI fellowship trained radiologists, which is very important too, because if you're going to have a really hard test done or a really complex test, we want to have it read by somebody who knows how to interpret that best, and they're excellent. We also have digital mammography, which is important. Definitely gives a better exam for women who have dense breasts, younger women, and for the BRCA gene positive women, better than standard mammography, but again, MRI is probably the best for that. And do you have any other questions? Sure.
How long did you say it's been available here?
The BRCA gene
your
testing?
Office, yeah. The testing.
Well, years ago, we weren't able to get it done because the insurance wouldn't pay for it unless you actually were seen by a geneticist. So we would have to send the patients down to like University of Michigan or another place where you could have a geneticist go through all of your genetic information. So I think that we've been doing it for about 3 or 4 years now.
Okay.
And it hasn't been readily available to surgeons, family practice doctors, oncologists before that time. And it was specifically because the insurance wouldn't cover it without a genetic counseling exam first.
Well, that makes sense. I had it done 5 years ago.
You probably had to go travel quite a ways to do it.
No, actually Riverside Medical sent it out, but I feel like it was sent out of state.
It may have been.
And because I have 2 sisters with the gene. I think it's BRCA2. Have to double check. But my results came back negative. But now I hear the false negative thing, and that gets me worried.
Well, it's actually, in your situation, it's actually very good, because if you have a positive family member who has the gene, or 2 in your case,
yes,
they are able to specifically look at that gene, and they can see if you have that bad gene. So
Okay.
it's less likely to be a false negative in you than it would be a general population, because in everybody else, we don't even know which gene, where there's tons of different genes, tons of things. So they're looking at a specific one for you, so it's a much better test for you.
Yeah, they were tested first, and so
Right.
you're right, they were looking for specific.
Exactly.
And then the cost was way reduced also.
Well, that's good.
You mentioned the double cancer at a time. My mom had breast cancer, and then 5 years later in the same breast had inflammatory cancer in that same breast.
So that would certainly count as 2 breast cancers. Because she had 2.
As you went through all of these different possible situations very quickly,
Well,
which is fine, but
to belabor you with all of those details at this point is just really, really hard to wrap your head around it. I've read it 1,000 times, and I still read it specifically every time I fill it out for a patient to make sure I have it right.
No, but what I'm thinking is that I did not fit into any of those categories.
That's fantastic.
Yeah, except that my grandmother on my father's side died of breast cancer. One of her daughters had breast cancer. Another one had something else related to breast cancer, but it wasn't breast cancer. My sister just passed away from breast cancer. And I've had breast cancer on one side 15 years ago, and I'm fine.
Well, I think you do fit into that category then. Maybe I should read a little bit slower, I'm sorry. But that would be a person who is diagnosed with breast cancer and has more than one family member who has breast or ovarian cancer. So you would certainly qualify for the test based on that information, because you have a 1st degree and 2 second-degree relatives.
And so then the test would be for one of the BRAC things?
Yep, 1 or 2.
Okay, 1 or 2.
And are any of those family members available to be tested? Because if we could test them, then the rest of your family wouldn't have to be tested. But no.
No, I'm the only living soul at the moment.
Then you would be the person.
How long does it take for the results?
They usually take about a week or so to come back. Depends on the limiting factor is usually the insurance company is making sure that the insurance is going to cover it first, because we certainly don't want patients to all of a sudden get a $3,000 bill. And they've been very good about that for us, which is nice.
So when you said except for disability and life insurance, does that mean that they can actually prevent you from getting that later on in life by doing this testing?
Absolutely.
So that's something that you specifically make sure patients understand?
Absolutely. And really the emotional part about it, I think, is, I have patients who think about having it done, and I ask them to think about, are you going to do anything with this information? Because if you're not, the information might be really burdensome to you. But if you're going to act on the information and you want to know, then I think that the emotional part of it is almost a little bit easier than planning everything in your life ahead of time. Because I have several patients out there who want to get their life insurance, their long-term care insurance, their disability insurance, all that stuff that's set up ahead of time first, but they maybe don't want to buy it quite yet. So they're waiting till they get it purchased and then they'll go ahead and have the test.
But they couldn't cancel you from it if you're in having.
If you don't
That's
tell
my
them-
thing.
I don't think so. I don't think so, but you have to look into your individual policy, because I think that that's an area that is a little bit slippery. Insurance companies can be slippery.
Do you know anything about how the Affordable Care Act will have anything to do with this?
There was a provision in there that they can't charge you more for insurance based on that. And that's as specific as I could find on it, is that they can't, because you have a genetic or a historic problem, they can't change what you get, what your premium is.
I thought that cost was supposed to be coming down because they weren't able to patent the test or something, or wasn't there some?
It's very possible. The information that I have is from the NCCN. So that's the information, that's the number that I quoted. But I'm certain that there are not different numbers that float around.
I have a niece who was tested. Her mother died of cancer, breast cancer. That would be my sister. So she was tested, and she's trying, because she has daughters, and she's trying to build kind of a family history. Would I go through her physician? I mean, if I decided to get tested to help her out in some way.
Oh, because she can't be tested?
No, she was tested, and she's just trying to figure out. I think she and her doctor are trying to build a genetic map or something.
Well, she's a second degree relative, so you'd have about a 25% chance of having the gene. So, except for her mom, probably. Is she positive?
She was negative.
She was negative. Okay, so if she's negative, and you don't know if her mom's positive.
She's
deceased. So it's hard to know.
But she was my sister, and my mother also had breast cancer.
So if you have a mom and a sister,
aunts and cousins.
Aunts and cousins, then you probably would qualify to get tested as well.
Right, but would I go through? How would I do? I mean, do you get tested, send it to that person who's building this? That she's trying to build, you know.
Who would you share the information with? It's
well, where do you start? I mean,
where do you start? I would say if you came back with a negative test, that's helpful, but only 50% helpful for her.
Right.
If you came back, and it's really 50%
She's
helpful for her
siblings.
either way, because if you were negative, you only had a 50% chance of getting it, and if you were positive, she still only has a 50% chance of getting it from her mother. So it doesn't.
Right.
It's still a 50-50 for her. She probably needs to be tested if it's her information.
Yeah, she was. But yeah.
So if she's truly negative, then her children are okay.
But what about her other side of her? I mean,
Her sisters.
her siblings, or I don't know. I mean, like her husband, or I mean, how? If she's negative, then her kids, she doesn't worry about them?
She can't pass it on to her kids if she doesn't have it.
Okay, that's true.
So she's
Her
probably...
dad died of cancer also. She's just trying to figure out what's going on.
Well, she'd probably go back into then the family history section where she had her mom who had breast cancer, and it depended on how old her mom was, so it's about the 2 to 2.6% chance that she would get breast cancer based on just that.
Right.
So,
right.
I
So
mean,
that's part of the whole picture.
Right.
So if she's trying to build this history for the family.
I'm not sure testing you would help her a whole lot because she's negative. It would help you.
Right. I'm just saying, yeah.
Right.
If the male died of this prostate cancer, though, would that be an important thing for the daughters to know?
Well, if he died of prostate cancer and he passed the gene down to her,
Right.
but she didn't get the gene, so it still doesn't affect
No,
her.
true.
She's tested and she's negative.
Right. Yeah.
So for her kids, she's already negative. So
She's pretty happy.
Yeah, I'd be very happy. That's great. That's
very
great information.
I think there's just families out there that are trying to build some kind of genetic picture, you know, and just trying to figure out how to help each other. I've got cousins who are trying to figure stuff out, and you know, it's just kind of interesting.
It is very interesting, and it's
How best
very
to help
complex when you start building a
understand.
pedigree.
Right, right.
Are there any other new ways of knowing whether or not you have breast cancer that might not have been discovered 15 years ago? Something like that?
The one that comes to mind right off the top of the bat would be ductoscopy, meaning that if a woman had, not related to this at all, but a woman who has a nipple discharge, you can use a small camera and actually go down into the ducts and look for abnormalities within the ducts, and that's a relatively new thing. The other thing that also comes to mind is the breast MRI, because mammogram is very good. Digital mammogram is better, and that's been within the last probably 10 years. You probably know that better than me, maybe 10 years. We've had it for 5, 6?
At least.
At least. But then MRI shows you a very detailed picture of the breast. It's almost like a CAT scan of the breast. So you get different slices of the breast, so it separates. Sometimes, like if you have a density here and a density here on the breast and you line them up just right, it will look like a lump on one picture, but then there's not a lump on the other picture. So sometimes it's important for you to get slices of it so you can see that they're two separate things. Or it might cover up something that's behind it. So what we find with MRI, and the reason we don't use it for everybody is, one, it's very expensive, two, it's very claustrophobic. Does give some dialogue to patients. But the other thing is you find things in a very, very sensitive way. So if you find an abnormality in MRI, it has a very small chance of being a breast cancer, versus if you find an abnormality on mammogram, it has a much higher risk of being a breast cancer. So that's why we don't do MRIs in everybody.
If you are at high family risk and you've been doing digital x-rays every year, mammograms every year, should you do an MRI every once in a while, or?
That's a very good question, and the way that you can get an MRI covered is by bringing in your family history, and we can put it into what's called a Gale model and plug in your lifetime risk of breast cancer. And if your lifetime risk of breast cancer is greater than, I want to say, 10, then you can I can call the insurance company and say, you know, this woman has very dense breasts, it's a difficult exam, she has a lifetime risk that's high, can we please get an MRI? And then that way we can. Otherwise, they're very expensive too.
If money and the insurance company went out for a picture,
Then I
how
would
would
get
your
an MRI.
answer? Would you just have an MRI every year?
Probably not every year, but every couple of years I probably would.
What's new in the world of triple-negative breast cancer as far as treatments and metastasis and stuff like that? Anything?
There is a brand new drug that just came out, and I can't remember its name. I just talked to Dr. Smith about it on Tuesday. And there's a new drug for triple-negative breast cancers that are more than 2.5 centimeters. So normally we consider a big breast cancer about 4 centimeters, but these are 2.5 centimeter breast cancers. So if you biopsy a triple-negative breast cancer that is smaller than what we would normally consider big, we can give preoperative chemotherapy. So we give this drug before we do the surgery. So that is a very new drug that's coming out, and Dr. Smith is working right now to figure out whether or not we can get it here if we need to. It's not very common.
What's the name of it? Do you remember?
I can't remember its name, I'm sorry.
I remember reading about something.
Yeah, it's a brand new drug out, and that's helpful because if you think about, I try to think about breast cancer like a dandelion. If you get it when it's still green or yellow, and you can just take out the whole dandelion, get the whole root. Well, that's how we treat the breast. But if it's already turned white and is starting to spread its little seeds around, then you need to weed and feed the whole garden, and that's chemotherapy. So if you think about breast cancers that are already big or already spread in the lymph nodes around, the thing that's going to save your life is the chemotherapy, because that's treating your whole body.
Isn't that the only thing that basically that will treat the triple-negative is the chemotherapy?
Well, surgery as well, you need to get rid of it, but yes, absolutely.
A lumpectomy or whatever,
Absolutely.
and then
Yeah.
chemo, because you
But
can't
this-
take
but
the
the-
tamoxifen in that,
Yeah.
right? So,
But exactly. The source prevention isn't, or the source removal isn't as important, meaning the surgery isn't as important in a triple-negative breast cancer, especially any breast cancer that's already spread. It's that whole body treatment, or the weed and feed, that's going to keep you alive. And that's why that's so important. So that's where the research is going now, is early detection to catch it before it's spread, and then also the different chemotherapies to take care of the tumors that are outside of the breast already.
And what kind of treatment for if there was any type of metastasis to like the liver, lung, brain?
As far as actual tumors,
Yeah.
I'm not sure that they're doing a whole lot with radiofrequency ablation or cryotherapy, but isolated tumors from the colon sometimes will be treated in the liver with actual surgical intervention. Chemotherapy can be directed to the liver specifically. I'm not sure it's very effective in breast, but in cancers that do well with metastases, like colon cancer, there's a lot more research and there's a lot more done with that. So it's still standard chemotherapy. I've never heard of anybody having a liver resection for breast cancer metastases, although it doesn't usually go to the liver. It goes to the bone in places that you just can't take out. It goes to the brain, you can't take that out. So breast cancer is kind of one of those ones that's hard to get rid of once it's out of its breast, unfortunately.
Any other questions?
Do you feel that the excess amount of estrogen in the environment in our lives is contributing to cancers and early puberty?
I would have to answer that based on my own bias, not any research that I've read, but my own bias is yes, and I try to provide hormone-free cheese, milk, and other things, especially to my daughters. And I don't drink it at all myself anymore. But that's my very personal opinion, not
I'm sorry, you try to provide what? Kind of
hormone-free milk.
hormone-free.
Right.
And how do you determine what's hormone-free?
Well, you can get the kind that, it says it right on the container, but also Gilbert's out of Marquette is all hormone-free. So all of their cheeses and butters and things, it's cheaper than the organic stuff. So that's what I get from.
I do have a question. If you have two relatives, say mother and an aunt, that both had breast cancer after age 60,
Okay.
and my mother has survived 20 years. My aunt passed away, but it was basically from kidney failure. It didn't have anything to do with the breast cancer, although they did have her on tamoxifen.
Okay, so it probably wasn't a triple negative, so that's good information.
So my question is, in that case, should I be tested for that?
So they were
A mother and an aunt.
a mother and an aunt, and one of them for sure wasn't a triple negative. And
Right.
do you know how old they were? You guys said over 60?
Right, my mother is 85 and she's been cancer-free for 20 years.
So hers probably wasn't a triple negative either, because she probably wouldn't have done so well.
Okay.
Especially having been when she was treated, because we didn't have as good of treatment then.
Right.
So I would say that you would be in a really gray area, and you'd be one of those patients where I'd be reading every single line to see that we had it done correctly. But then what I would encourage you to do is to go back and research anybody in your family who's had prostate cancer, pancreatic cancer, melanoma, ovarian cancer, because if you have those might put you into a category
My
where it
mother
would be
had
worthwhile
melanoma,
testing.
and my grandfather did on my mother's side,
Yeah.
and my
so,
father had prostate cancer.
Yeah, so I mean,
Right.
all of those things tend to put you into a higher risk category. So we'd have to build you a pedigree and to take a look at all of those and see, do they line up? Are they all in the same line? And if they are, then it might be worthwhile for you to do the testing.
Okay.
And the other thing is you know, like I said, a lot of these breast cancers occur at very young ages too. So the fact that you're past 39 is great and you didn't get a breast cancer.
No.
So that's
The doctor that I had told me when I explained to him about my mother and my aunt, he said, when you reach menopause, he said, no way can you take any kind of hormone replacement therapy. None.
That was probably good advice, especially since they placed your aunt on tamoxifen, so hers was estrogen receptor positive.
Yeah, after she had that, she had a reaction, I believe, to the tamoxifen, and she had kidney problems. She was on dialysis before she died. So the tamoxifen has some serious side effects if you aren't careful with that. When you take it, it opens up the door to other serious illnesses.
And one of them is uterine cancer too. So
And
that's,
no one in my family's had that.
but estrogen or tamoxifen.
Oh,
can be
tamoxifen,
reset,
yeah.
Is that, you know, if I were to research my family, it would be, I don't quite, or if I were to build this, you know, I don't quite know how I would gather the information.
It's very difficult to do that. And one of the things, one of the slides that I didn't show you is that you have limited information, meaning that you don't have 2 first or second degree female relatives that have lived beyond age 45 because you're adopted or they died before then or you don't have them, then that would be another reason to do the testing. All we can do is go on the information that we have. It sounds like what you described before sounded like enough information.
For me, both of my sisters had cancer in their late 30s. One had cancer again, and then the second we had the preventative mastectomy. But it's through my father's line, and it was my grandfather and both of his sisters both had, well, lung and breast, or they all did. But my father has shown no signs of any, and I have a brother too who has not been tested yet. But
when we go back and look, though, they only have a 6 to 8% chance of getting breast cancer, so they still don't have a very good chance of getting breast cancer, although they have the mutation.
Okay.
And for them, you'd want to watch for prostate cancer, make sure that they get tested, make sure that they're followed, and make sure that they have early treatment. But even so, it's still an aggressive prostate cancer when they do get it.
Okay.
Any other questions?
Okay, well, thank you so much for having me.
And as I mentioned, we do maybe one of these a month too. We've had so many people who have had an interest in the Affordable Care Act and what it will mean for people that we are going to do a presentation next week. Make sure I get this right. October 23rd, which is a Wednesday, 6 p.m. here. And it's going to be David John, the CEO of the hospital, is going to be talking, and also someone, we don't know exactly who yet, from CHAC, the Chippewa Health Access Coalition, is going to be here as well. So if you can make that, we look forward to seeing you, and thanks again for coming.